My grateful thanks to the Medical Education Academy for their kind invitation to present at this webinar for nurses and midwives. And whilst the focus is improving implantation potential, we need to consider lifestyle factors that inhibit or aid implantation and fertility treatment outcome. And this is my declaration in which I have acknowledged receiving an honorarium for this presentation. So the learning outcomes of this session are the awareness of modifiable factors that impact both male and female fertility, the impact of advancing female age, including physiological factors, stress, and the impact this has on mental health and well-being. I'll also cover the harmful effects of the most commonly used recreational substances and supplements, both evidence and non-evidence-based, and the availability of treatment add-ons, all of which impact either directly or indirectly on endometrial receptivity. And finally, I'll explore the role of the internet and patient dependence for information and support. The available evidence suggests that lifestyle factors such as diet, quality of sleep, environment, and other behaviours have profound effects on health and disease, with fertility being no exception. I'm a firm believer that mental and physical health are inextricably linked, and if you don't have one, you don't have the other. Whilst the lifestyle focus tends to be on women, a number of lifestyle factors affect both genders, and these are limited not just to diet, BMI, exercise, and stress, but include environmental and occupational exposures such as smoking, alcohol, substance misuse, and certain medications. According to Gaskins and colleagues from the US, the evidence to suggest a potentially detrimental effect of moderate alcohol and caffeine intake on fertility appears to be lacking. They go on to suggest that the most salient gaps in the current evidence include consideration of both female and male diets and testing the most consistent findings in a randomized controlled trial. There's no doubt that female age is the largest predictor of fertility treatment outcome, and it's well known that female fertility potential begins to decrease after the age of 30 years, primarily as a result of a decrease in ovarian reserve and available oocytes, and as a consequence of a continuous process of oocyte atresia. The age-related decline in fertility is also characterized by a decrease in both oocyte quantity and quality, in addition to changes in the expression of biomarkers of ovarian activity, such as increasing levels of FSH, decreasing levels of anti-Müllerian hormone, and inhibin B. Nevertheless, women want to know their individual chances of success and time to pregnancy, something the Poseidon criteria has actually given us help with, all of which can be determined by the various factors listed in this slide. Medical history also plays an important part in this prediction. Maternal history of premature menopause, previous exposure to certain medications such as chemotherapy and methotrexate, which is commonly used in the treatment of autoimmune conditions, in addition to smoking, are all considered contributory factors in the decline of ovarian reserve. And as we've known for some time, previous smokers are often reliant on an increased dose of FSH for ovarian stimulation. So, given female age is the single most important factor in assessing ovarian reserve, it's also linked to an increased risk of aneuploidy, obstetric risks, and fetal anomaly. Interestingly, low AMH concentration has been associated with an increased risk of embryo aneuploidy in women of advancing age, but not in younger women, suggesting that embryo aneuploidy risk was mainly due to advancing age and related to changes in oocytes and not to ovarian reserve in isolation. Endometrial receptivity might decline with an advanced age due to unknown biochemical or molecular abnormality of the endometrium, and this decline could also be the result of a higher incidence of other pathological conditions in the uterus, such as myomas or polyps. In addition, hypertension and other systemic disorders are more common in older women and could be contributing to the reduced potential for implantation and successful pregnancy outcome. However, donor eggs have provided women of advancing age with an increased chance of success, but obviously not acceptable to all. Researchers in Barcelona found that the chances of women having a baby through IVF was only 1.3% using their own eggs in those aged 40 years and above. But when using donor eggs, increased considerably to 24% in women aged 38 to 39. Obviously, they didn't account for women over the age of 40. Therefore, fertility nurses have an obligation to be honest with women and to raise awareness of age-related fertility decline and to remember that social egg freezing may not be the answer. Obviously, this is dependent on age at time of storage. The literature further suggesting that on average, women would require between 10 and 15 metaphase 2 stage oocytes to give a reasonable chance of live birth. With regards to physiological factors, stress is a prominent feature across all societies, whether physical, social, or psychological. Living with infertility is stressful, and societal pressures such as friends announcing pregnancy, monthly testing for ovulation, or frustration associated with irregular cycles, repeated treatment failures, disruption to one's life plan, in addition to the financial costs with which fertility treatment is often associated. The hypothalamic pituitary adrenal axis, when activated by stress, exerts an inhibitory effect on the female reproductive system, with cortisol inhibiting GnRH secretion and glucocorticoids inhibiting pituitary LH and ovarian estrogen and progesterone secretion. These effects are responsible for the hypothalamic amenorrhea of stress, which is observed in cases of anxiety and depression, malnutrition, eating disorders, and also in chronic excessive exercise, low BMI having an equally negative effect on fertility as raised BMI. Males who experience more than 2 stressful life events before undergoing fertility treatment were more likely to be classified below the WHO standards for all sperm parameters, with stress and depression thought to reduce testosterone and LH pulsatile action, which disrupts testicular function. A healthy body mass index is important for fertility, and this should be, for women, between 18.5 and 24.9. Given women store almost a third of the required level of estrogen in their fat cells, those with excessively low BMI will also experience menstrual dysfunction as a result of pituitary suppression, excessive exercise and top athletes being a prime example. This group of women are predisposed to reduced bone density and osteoporosis later in life. With regards to men, male obesity has also been linked to reduced semen parameters and has also been suggested that high-fat dietary exposures could affect the epigenetic content of sperm or the endocrine content of seminal fluid and thus impact early fetal development. With regards to physical labour, a study by Stanford University in California suggested that men who were exposed to intense physical labour in the workplace were twice as likely to have a low sperm count. The same study also reported that using certain medications or an increased number of medications lowered sperm concentrations. And finally, men who rely on anabolic steroids for building muscle mass are at an increased risk of inducing negative feedback on the hypothalamic pituitary compound and inhibiting both FSH and LH secretion, leading to either oligo or azoospermia in addition to hypogonadism. So with regards to preparing our patients for their fertility journey, it's really important to remember that they lead busy and successful lives out with fertility treatment, and that we have a duty of care to ensure they are well informed and supported throughout. I've therefore actually taken some patient perspectives from the UK HFEA website. The HFEA is the regulator for all licensed clinics in the UK, with the majority of these statements accessed from the patient testimonials. Fertility nurses and midwives are best placed to advise patients on the importance of self-care and not to focus purely on the physical aspects of IVF. For some, IVF is not simply a physical challenge, but according to this patient, a mental marathon also. So ensure your patients appreciate that everyone is different and they will receive quality care that is individualized to their specific needs. There are many aspects of fertility treatment that patients couldn't control, for example, antral follicle count, number and quality of embryos, and treatment outcome. However, patients can shift focus to what they can control, for example, their mindset, attitudes, and outlets for stress. They can also put practical coping mechanisms in place. There's no denying that fertility treatment is a stressful life event, whether it's managing multiple clinic appointments, juggling work commitments, or telling friends and family that they're going through treatment. Whilst there's no known studies to show that stress impacts on the physical outcome of fertility treatment, patients should be encouraged to be open to emotional support and aware of the counselling options available to them at their clinic. But most importantly, ensure they take time to relax and unwind and do what feels right for them. And if that means fitting appointments into their daily routine that involves going to the gym or socializing with friends, then this should be encouraged. It's also well documented that cigarette smoke contains over 4,000 chemicals and is associated with a number of potential health complications such as cardiovascular disease. But more research is needed to establish a link to infertility. Ogood and colleagues determined that women who smoked had a significantly higher odds ratio of infertility in comparison to non-smokers. The reduction in fertility among female smokers may be due to a decrease in ovarian function and ovarian reserve. Men who smoke tend to have a decrease in sperm count, density, motility, morphology, semen volume, and also fertilizing capacity. One study also determined a link to reduced binding capacity. Alcohol has also been associated with multiple reproductive risks, including fetal alcohol syndrome, but obviously that's linked to excessive alcohol intake, and an increased risk of early pregnancy loss. But how much is too much? According to a study by Lingsgo and colleagues, low to moderate average weekly alcohol intake and the chance of achieving a clinical pregnancy or live birth following treatment was not statistically significant. Yet, our recommendation is also always to abstain from alcohol when trying to conceive. Studies of the effects of illegal drugs on human fertility have been scarce due to the ethical considerations, as well as subject to underreporting and bias due to the characteristics of the population being studied, and often, as stated in this paper, attributed to low socioeconomic status or lack of antenatal care. Marijuana, more commonly known as cannabis, is one of the most commonly used drugs around the world and acts both centrally and peripherally to cause abnormal reproductive function in both genders. Therefore, the use of recreational drugs appear to have a negative impact on fertility, although we know that more in-depth research in this area is required to make a clear link between the two. With regards to supplements, clinical evidence on the role of antioxidants in female fertility is also scarce. However, there is good quality evidence for the supplementation of both folic acid and vitamin D. The World Health Organization strongly recommends all women of reproductive age to take 400 milligrams of folic acid pre-conception, in addition to consuming food with folate from a varied diet in order to prevent neural tube defects. A higher dose of 500 milligrams is recommended for certain groups of women, for example, those with previous history of neural tube defect, diabetes, malabsorption, and smokers. However, we must never forget that the richest source of folic acid may in fact be from our diet. Vitamin D, as we know, is a fat-soluble steroid hormone with several physiological endocrine functions in the female reproductive system, and is also known as the sunshine vitamin. Additionally, it is involved in the regulation of ovarian and endometrial cell proliferation, something I actually didn't know before I prepared for this talk. And women are advised to supplement vitamin D during pregnancy to maintain recommended levels of calcium and phosphorus. However, with regards to fertility treatment outcomes, Vitagliano and colleagues suggested serum levels of vitamin D didn't actually influence treatment outcome, raising some concerns about the expected efficacy of these ingredients in commercially available products. Coenzyme Q10, or CQ10 as it's more commonly known, is a free radical scavenger acting as an antioxidant and playing a crucial role in the regulation of metabolism. The limited evidence suggests that it plays a role in the protection of female gametes from oxidative stress, yet only poor quality studies exist which suggest supplementation was associated with a slight improvement in egg quality in both animal and human studies, with a potential role in the prevention of post-ovulatory aging in infertile women, a finding which I would absolutely apply with caution. With regards to DHEA, the minimal evidence available suggests that it improves ovarian function, increases chances of pregnancy by reducing aneuploidy, and lowers miscarriage rates. Nevertheless, some would argue that improvement of egg and embryo quality with DHEA supplementation potentially suggests a new concept in the prevention of ovarian aging, where ovarian environments, but not eggs themselves, age. However, robust quality studies are required to disprove this, as in my opinion, female age will override this benefit every time. The findings of Vitagliano and colleagues also raise serious doubts about the potential effectiveness of most commercially available dietary supplements for improving outcomes of fertility treatment. In the UK, an agreement between the UK regulator, the HFEA, and 10 other professional and patient bodies in 2019 suggested that treatments with no strong evidence of their safety or effectiveness should be offered in research settings only, and patients should not be charged extra to take part in research or clinical trials. The HFEA therefore introduced a traffic light system, attributing red to add-ons with no evidence for their implementation, amber for limited evidence, and green for good quality evidence, all of which should be incorporated into clinical practice. Given the focus of this webinar is improving endometrial receptivity, I've included endometrial receptivity array, ERA, but in healthy patients is rated red by the HFEA because there is absolutely no evidence from randomized controlled trials to show that the procedure improves implantation rates. Another considered add-on is endometrial scratching, which has been given an amber traffic light rating because there is conflicting evidence from RCTs to demonstrate its effectiveness. And finally, immunological tests and treatments for fertility has also been given a red traffic light rating because there is absolutely no evidence for its implementation in healthy patients. So endometrial preparation is one of the most important steps for ensuring embryo transfer success. However, there's no clear evidence that identifies an optimal endometrial preparation protocol for frozen embryo transfer. The preferred approach appears to be HRT preparation, which, in addition to improving outcomes, also allows for clinic planning. However, some women actually fail to respond to this approach and at mid-cycle ultrasound assessment present with reduced endometrial thickness or dominant follicles, suggesting an ovulatory cycle which wouldn't allow for accurate synchrony with the date of transfer, embryo development, and duration of progesterone. In addition, many studies have attributed treatment success to endometrial appearance at the time of transfer and visualization of the triple line on ultrasound. With regards to luteal phase support, Elena Labarta and colleagues from the IVI group in Spain published data on the threshold of serum progesterone on the day of embryo transfer in HRT cycles to improve treatment outcome. And in a subsequent study, they demonstrated an increased implantation rate when adding subcutaneous progesterone to vaginal preparations on the day of transfer, and that's something we have actually found beneficial in Aberdeen. A recent debate published by Jacobs et al. In Fertility and Sterility and entitled "How Thin is Too Thin" suggests a pragmatic approach with no clear consensus on endometrial thickness or appearance. With regards to egg, sperm and embryo quality, I know that Rachel will cover this in her presentation. There's no doubt that women in particular refer to the internet for information. However, information from different sources can be conflicting. In a study by Jones et al. In 2020, patients were directed to educational material on common fertility topics in text and video format posted on the clinic website and social media accounts. They concluded that patients found online fertility information useful for making treatment decisions and had the potential to improve patient care by empowering patients with the knowledge to make more informed treatment decisions and improve the quality of time spent with the fertility nurse or physician. However, bearing in mind that study actually used very carefully audited and screened information. There's also, as we know, there are some excellent online resources, but there's also a lot of harmful information and inaccurate information out there. And we need to be aware of the Dr. Google effect when patients attend consultations with information or Google research they've obtained online. However, living with infertility can feel isolating, and the internet can actually provide anonymity, emotional support, and normalization for some. Therefore, online infertility networks can play a valuable role in helping people deal with the emotional stress and isolation they feel during and after treatment. However, it also has the potential to reinforce isolation. So it's therefore our responsibility to direct patients to reputable websites and patient decision aids and ensure adequate emotional support before, during, and after fertility treatment, irrespective of outcome. So in conclusion, lifestyle choices do count. Therefore, awareness of modifiable factors that affect fertility is really important. And this includes reducing stress and the intake of substances, which are thought to be harmful to fertility. Advancing female age is the most accurate predictor of the overall chance of success through natural conception or fertility treatment. And to date, evidence has yet to refute this. However, physiological factors require medical intervention, which should be evidence-based. And finally, as fertility nurses and midwives, we have a duty of care to ensure our patients receive accurate and honest information, in addition to appropriate emotional support before, during, and especially after fertility treatment, irrespective of outcome. And these are my references, which will be available to delegates after the event.